Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Good morning and welcome to another edition of our Saturday Health Hour. I'm delighted for those of you that are able to join us live, and for those of you that are watching this recorded, I hope you get all you wanted to out of it. My name is Ngozi Ediosage. I'm a paediatrician and neonatologist and I work in Manchester. I'm also a visiting professor at Manchester Metropolitan University. I'm delighted to welcome you today. And in addition, I'm also delighted to welcome our speaker this morning. In keeping with our theme for the month, as you all may recall, at the beginning of this month, it was International Women's Day. And in keeping with that theme, we continue to have a focus on women's health. We really want to encourage women to empower themselves and to understand more about their bodies. And we've had a range of topics looking at women's health in particular this month. So continuing with that theme, I'm delighted to invite Dr. Patrice Arthur, who is a gynecologist at Manchester Foundation Trust at North Manchester General Hospital. She's going to talk to us today about chronic pelvic pain. One of the things that we really advocate in these sessions is to listen to our speaker, but also it is a very interactive session. So if you have questions, personal or otherwise, please pop them in the chat box. If you would like to make those questions more personal, please direct them to me, Dr. Ediosage, and I will ask them on your behalf. So Patrice, welcome, and I'm really looking forward to another really interesting session. Thank you, Patrice.
Thank you, Ngozi, for having me again, especially this month, International Women's Month. And it's great to be chatting with you again about women's health. So I'm going to share my screen with you. And we're going to talk about pelvic pain in women. And you can imagine this is a very complex topic. It's difficult because there's so many different etiologies involved in pain and in pelvic pain. So first, we're going to talk about what the cause of pain can be. We do know, though, that the uterus, the cervix, the ovaries, they share the same nervous innervation as the lower sigmoid colon and the rectum. So sometimes it's difficult to distinguish the pain of gynecological origin from the lower GI origin because they share that same nervous innervation. So, but we can divide the causes of our pain into those caused by the female reproductive tract, the GI tract, the musculoskeletal system, and the urinary tract system. So I'll first talk about chronic pelvic pain. Okay, so we do know that it affects 1 in 7 women, mostly between the ages of 26 to 30. All the women in the reproductive age group can all suffer from chronic pelvic pain, even in menopausal ladies as well. And I'll talk about that as I go along. So a study found that they were more prevalent in Black women, maybe because of the various conditions that cause chronic pelvic pain are more prevalent in Black women. And it is described as continuous pain that is non-cyclical, lasting for more than 6 months. And this pain is usually localized to the abdominal wall between the organs and the pelvic wall and the lower back. We know it could cause severe depression and anxiety, disturb sleep, reduce mobility. Women can avoid school, work, social commitments. It can sometimes be associated with drug abuse or dependence, and can cause family and marital and sexual problems, as you can imagine. Sometimes there's a history of physical and sexual abuse as well. So it's something that we need to take seriously. So this diagram just shows us an example of certain conditions that can cause chronic pelvic pain, pelvic inflammatory disease, painful bladder syndrome, irritable bowel syndrome, adhesions, nerve entrapment, and there is that subgroup where the cause of pain isn't found. So we go through those things as we go along. So as I mentioned, pelvic inflammatory disease, endometriosis. I know there was a chat about endometriosis and fibroids about 2 weeks ago by Eddie Osaki, so I wouldn't go too much into it, but I will mention it as I go along. Condition called adenomyosis, uterine polyps, and prolapse, and these are other conditions that can cause chronic pelvic pain. Musculoskeletal pain occur in about 15% of women who have chronic pelvic pain. You sometimes have trigger points, which are areas overlying the muscle that induce spasm and pain. And they're often located in the pelvic floor. So the pelvic floor, those group of muscles that support the cervix and the uterus. And sometimes you can have areas of spasm in those areas, and they can coexist with other conditions such as fibromyalgia. Sometimes hernias can cause chronic pelvic pain, nerve entrapment, osteoporosis, and as I mentioned, pelvic floor dysfunction. Causes of chronic pelvic pain due to the urinary tract and system would include interstitial cystitis, which basically is inflammation of the lining of the bladder, and is associated with urgency, where you have to go to the toilet, as soon as possible, or you may leak. Pain associated with passing urine, low abdominal pain, and back pain. So what can cause pelvic nerve damage? As I mentioned, you can have nerve entrapment. You can also have nerve damage from conditions such as diabetes. Diabetes can affect the nervous system in the body. During surgery, you could have damage to your nerve supply to your organs. Excessive stretching during surgical procedures as well can damage the nerve supply to the abdominal wall, and excessive compression, such as prolonged sitting or standing. Now, I want to mention acute pain, because pain is our body's warning system that something is wrong and that we need urgent medical attention. So if you know you're pregnant, or some women don't even know they're pregnant, but they can get an acute onset of pain. That acute onset of pain would need urgent attention. So things such as ectopic pregnancy, so that's a pregnancy that's not in the correct place, it's in the tube or outside of the womb, that can cause acute pain, miscarriage or abortion, degeneration of a fibroid. So that occurs in pregnancy where the growth of the fibroid is so fast that it outstrips its blood supply. And as a result, the inner part of the fibroid doesn't get a blood supply and it basically dies, and those cells die, and that causes pain. So that's called degeneration of the fibroid. Endometritis, which is inflammation of or infection of the lining of the womb. PID, pelvic inflammatory disease, can cause both acute and chronic pain, as well as tubo-ovarian abscess. You can have a ruptured ovarian cyst that could just rupture and cause acute pain, or it can twist, called ovarian torsion. Again, that would necessitate urgent medical attention, as well as gynae cancers. So you have other symptoms involved in gynae cancers, irregular bleeding or bloating, loss of weight. So there'll be other symptoms as well, but we have to keep that in mind. Other causes of acute pelvic pain that don't have to do anything with the reproductive organs would include things like gastroenteritis, appendicitis, diverticulitis, inflammation of the wall of the bowels, constipation, especially in elderly patients, inflammatory bowel disease, and irritable bowel syndrome. As I mentioned, cystitis, things like kidney stones, kidney infection, that can cause acute pelvic pain. Other things such as physical or sexual abuse, we shouldn't forget these causes, at least when these women present to the hospital. We have to keep that in mind as doctors. Substance abuse, sickle cell disease in patients with that history, and pelvic congestion syndrome. So I've put that in other because it is a controversial diagnosis, and we'll talk about that a bit later on. So what causes chronic pelvic pain? So I mentioned the main things I'll talk about. Adhesions. Adhesions are fibrous connective tissue between internal organs and the abdominal wall. So they shouldn't be there, okay? They can be caused by injury, whether it's surgery, trauma, inflammation due to an infection, to the peritoneum, which is the lining of the pelvic cavity. And is often seen in endometriosis after surgery or with a pelvic infection. And it can be diagnosed at laparoscopy, where they do a keyhole procedure to have a look into the tummy. It can be divided, but they do tend to reoccur. So it's the body's natural response to injury. It just forms fibrous tissue. And once it's cut, you might get a temporary relief, but they do tend to reoccur. Fortunately, there's some fluids that can be used at the time of laparoscopy to kind of slow down or prevent the formation of adhesions. But these aren't 100% effective, and they're not perfect, but they can help. So fibroids, so I just want to talk briefly about fibroids. I know we've been through it several times. We know they're non-cancerous overgrowth of the muscle of the womb, where knot of the muscle forms caused by fibrous tissue and the muscle of the womb. We know it can vary in size from a few millimeters to tens of centimeters. And inherited genes play an active role in the etiology. They are sensitive to female hormones such as estrogen, and they grow in response to that. And we do know they shrink down after the menopause. So fibroids can cause no symptoms at all. Depending on where they're located and the size of the fibroids, they can cause various symptoms. Heavy periods, if they're located near the lining of the womb, they can cause heavy periods, prolonged periods, irregular bleeding. If they grow very large and press on the bladder or the bowel, they can cause frequent urination, abdominal pressure, and that feeling of discomfort. And they can impact on the bowels as well and cause you constipation. Sometimes where they're located as well can mean you can have trouble conceiving. So fibroids are a problem, but for some women, they actually are asymptomatic. And we know the treatment of that could be medical management, where you can have medication to help control your symptoms, such as pain and bleeding, medication as well to shrink the size of the fibroids. There's surgical options as well, where the fibroids are removed, or in a hysterectomy where the womb entirely is removed. And all these different treatment options should be discussed with your gynecologist. There's a non-invasive or non-surgical methods as well, such as uterine artery embolization, where the arterial supply to the uterus is blocked. And we have treatment to the fibroids itself using ultrasound frequency waves that actually shrink the size of the fibroids. So there are various treatments involved in treatment of fibroids. Another thing you will hear, or condition you will hear about, is adenomyosis. And this is similar to endometriosis. So basically, the lining of the womb is found where it shouldn't be, and that is growing in the layer below the lining, which is in the muscle. And as you can imagine, with your periods, you bleed into that muscle when you've got adenomyosis, and the blood is trapped and therefore can cause pain and heavy bleeding as well. It causes pain when having sex. It can cause fertility problems. It could be difficult to diagnose on ultrasound scan, and is better seen on the MRI imaging. Treatment would involve medications such as ibuprofen and hormonal treatment. So, treatment with the oral contraceptive pill or injections, hormonal injections. Also hysterectomy could be an option when all else has failed and you've completed your family. Moving on to causes of chronic pelvic pain due to the gastro system. You can have chronic abdominal pain from irritable bowel syndrome. You get other symptoms such as bloating, altered bowel habits. You find patients having relief of their symptoms just by opening their bowels. It affects about 1 in 5 people. And we basically think it's due to irritants, irritating the gut lining, and increased activity of the nerve supply in the gut, in the bowels. Exercise may benefit. Antispasmodic medications such as peppermint oil, buscopan, and some antidepressants. Now, antidepressants are not given because you're depressed or the symptoms are in your head, but it has been shown to be a pain modulator. So it helps the body to process that pain and to dull that pain with medication. So antidepressants have a role to play in chronic pelvic pain. Moving along to another common cause, pelvic inflammatory disease. That's inflammation of the womb, the tubes, and the ovaries. About 1 in 50 sexually active women can suffer from PID, common in the 20 to 29 year age group. There's risk of infertility, ectopic pregnancy, because it can cause scarring of the fallopian tubes, and that can lead to an ectopic pregnancy if you get pregnant. Most commonly, they can cause pelvic pain, painful intercourse, abnormal vaginal bleeding. and it can be associated with sexually transmitted diseases, chlamydia, gonorrhea, bacteria that exist in the vagina but travels up the reproductive tract to cause infection. Occasionally, it can develop after miscarriage or a termination of pregnancy, or even after insertion of the coil. And most cases are treated with antibiotics, but at times when the symptoms are quite severe, it will need to be diagnosed and treated by a laparoscopy. That's keyhole procedure, especially if there's an abscess that forms or the tubes get really dilated with fluid or with an infection and needs to be drained. So there are times it needs to be treated by surgery, but it's usually treated with a 2-week course of antibiotics. So painful bladder syndrome, this is a quite common cause of chronic pelvic pain. Another word for it is interstitial cystitis, and is inflammatory condition of the lining of the bladder wall. You commonly find ulceration of the bladder lining, swelling, and small vessels that bleed. And as I mentioned before, the symptoms are like urgency, frequency, and pelvic pain. And it could vary, the pain can vary from mild tenderness to intense pain. So it's an important cause of pelvic pain. Diagnosed by cystoscopy, which is a camera into the bladder. And the treatment, first of all, at times you don't always see that typical characteristics on the cystoscopy. It comes back negative, but because of the patient's symptoms, it's still diagnosed as interstitial cystitis. Some women find that it's triggered by certain food and drinks, so we ask them to avoid that. And we use certain drugs and medications, such as the antidepressants I was telling you about, not used to treat depression, but used to modulate the body's reaction to pain. And also some minor surgical options for treating this bladder condition. Now, pelvic congestion syndrome, as I mentioned, it's a controversial diagnosis. It's rarely diagnosed in the UK, but some claim it can cause pelvic pain. And usually women complain of pelvic pain or pressure that lasts for more than 6 months. It's worse with sitting down for long periods of time, and it can be associated with varicosities of the upper thigh and buttocks, pelvic and vulval area. Now, it's thought to be caused by damaged valves in the veins that lead out from the ovaries and that return to the heart. And these damaged veins cause blood to pool down in the pelvis. And gravity pulls this blood down, creating varicose veins around the ovaries and the womb and in the pelvis. So it's not something, it's not a condition that many gynecologists in the UK have been trained to actually diagnose and treat, but it is a cause, it can be a cause of pelvic pain. I think most gynecologists would see some sort of pelvic congestion when they do a laparoscopy for some other reason. And some of these women, most of these women don't suffer from pelvic pain. So that's why I think it's a controversial diagnosis for pelvic pain. We have a condition, persistent pelvic pain. So this persists for months, even sometimes years, where no cause of the pain is found. And 40% of laparoscopies, the keyhole procedure, there's no cause of pain. So everything looks absolutely normal. And in these conditions, it can be quite frustrating for women to find that there's no observed cause of pain. So that's where your chronic pain clinics come into use to good use, because women can be managed by pain specialists, by psychologists, can go through various different pain treatments, such as hydrotherapy, physical therapy, pelvic floor exercises, acupuncture, changes in diet. All these things have been found to help with symptoms. We know that stress can release adrenaline and cortisol, and that can increase your pain intensity. We know the things that help us to relax, exercise, meditation can increase your body's natural response to pain, endorphins. So it's important to engage in activities like that, although it's difficult when you are in pain. As I mentioned, drugs traditionally used for epilepsy and depression are also used because they're found to change the way that pain pathways process pain. They're known as pain modulators. So don't be surprised if the GP or your doctor or the pain specialist recommends such medication for you. So how do we go about making a diagnosis? So I think it's important to have a symptom diary. So there's an example of a symptom diary here. I'm not recommending this particular one, but I thought it was useful in that it makes mention of keeping a record of your daily symptoms day to day, including the pain scale. So if you can record your pain from 0 to 10 on a daily basis, that will help the doctors to see if there's some sort of cyclical pattern to your pain. If you can record the area of pain and the medications taken, that would also be useful. And in this particular diary, it concludes with a weekly and monthly summary. Also a medical journey. It's a good idea to write down the medications you've tried and tested, take note of the dosage, duration, and any side effects. And it would be helpful information to tell your doctor, well, I've tried X, Y, and Z, so you don't have to try it again and start from the beginning again when you go to see your gynecologist. So I thought this symptom diary was quite useful, and it's a good thing to present to your GP or your gynecologist when you have an appointment to see them. So the doctor will get a medical history from you, including your smear history. They will want to do a pelvic examination, abdominal examination to see if there are any trigger points, as well as a pelvic exam. And during that time, they would take swabs just to rule out any infection if you're at risk of that. They may want to do a pregnancy test if you fall into that age group. I know in A&E we do a pregnancy test as a routine on any woman coming through with pelvic pain that are in the reproductive age group. So don't be alarmed if they ask you for a pregnancy test. Other blood tests to see if there's any infection, inflammatory markers, urine dipstick test to check for any signs of a urine infection. Your GP, once taking your history during examination, may want to refer you to the gastroenterologist. If your symptoms are more bowel in origin, they may want to refer you to gastroenterologist who may do a colonoscopy, which is a camera procedure into the colon and the sigmoid. If your symptoms are more related to your reproductive tract, they will refer you to gynecologists, and they would and do the ultrasound scan. They may need to do an MRI scan if they're thinking you have adenomyosis. So the diagnosis based on general history examination. I found some useful websites when I was doing research on this topic. And I think they're really important for women who have been through hospitals, been through the clinics, having difficulties with diagnosis, and these support groups are actually crucial to women so that they know they're not alone in dealing with their condition. So the Bladder and Bowel Foundation, a confidential helpline with anyone who suffers from these conditions, Acupuncture Council, British Association of Nutritional Therapy, Endometriosis UK is also a very good resource. Endometriosis.org is the global forum for news and information of endometriosis. Headspace, again, for anyone with an interest in mental health and well-being. And the Pelvic Pain Support Network, again, a patient-led organization. So you find these websites particularly helpful in supporting you through your journey of treatment. So I want to thank you for listening, and I'll open up the floor to any questions.
Thank you very much, Patrice, for really a whistle-stop tour, but a really interesting review of things that cause pelvic pain in women. I was just going to ask you to stop sharing your slides, so that's fine. You've done so. So I've got questions already that have started to come through. So pelvic pain is one of those things that you go to your GP, and for this woman that has sent this question in, has said that she's been a number of times, but what interested her was when you talked about adenomyosis, and you said it's usually diagnosed on an MRI scan. So that means that if you have an ultrasound scan, you might miss it, is it?
That's right, yeah.
So how do you progress to an MRI scan? Because the problem is that, one, as Black women, where we are usually felt to be that we're stronger than everybody else, so we can sort of cope with the pain, there's that myth. And so how do you get across that your pain is out of the ordinary now and you want to progress to additional investigations?
Yes, it is a difficult question. In my practice, or as a doctor, I see women coming through with a lot of ultrasound scans. And sometimes on the ultrasound scan, they kind of query whether there may be some adenomyosis. It's not a definite diagnosis. Again, it's difficult to see on the scan. So the sonographer is usually the one that can detect that it might be present. And sometimes they do mention it on the scan and suggest an MRI as a follow-up. So that's one way. Second way is actually asking your gynecologist, do you think my symptoms are due to adenomyosis? Because remember, if you go armed with your symptom diary and your signs and symptoms, according to what you've recorded, are symptomatic of adenomyosis, I think your gynecologist should take you seriously and request an MRI for you. So it's about your signs and symptoms. And if you're certain of it, if you show that you are proactive on top of things, on top of your symptoms, then this would definitely aid in your diagnosis.
Thank you. I think it's important about the symptom diary. So if anybody's out here and is listening and you've come here because you looked at the topic and it says, oh, pelvic pain, you say, oh, that's me. To try and get an objective view of what's going on with you, having a symptom diary, it's really difficult to put somebody off or to back somebody off if they come with a diary that says, look, on most days I'm having pain. You can't then just fob someone off. So go armed with a bit more information. That's really helpful, and that's good information that you can take to your GP. So the opportunity to fob you off isn't there. There's another question here that says, this is someone of childbearing age who has a history of fibroids and adenomyosis and has previously had an open myomectomy. They said for their personal reasons, their personal circumstances, that the combined contraceptive pill is contraindicated. and they've had a perforation with an intrauterine device, so he's not able to have this either. What would be the sort of course or what sort of treatment options would somebody like this have who's still suffering with pain from adenomyosis?
Okay. And
is contraception, the pill is one of the things that may help, but for her it's not
right.
useful.
Okay, so again, your gynecologist will go through the medications that is suitable for you, and if the oral contraceptive pill is not suited, then that's contraindicated for your use. So if you are still a woman that wants to have more children, and you don't want to go through, even if you don't want to have more children, but you don't want to go through a major operation such as a hysterectomy, then the best way of dealing with this is symptom control using pain relief, because we know adenomyosis can cause a lot of pain. So ibuprofen, things like tranexamic acid, mefenamic acid, those are the non-hormonal medication that you can take for this, this sort of condition. Again, fibroids. If fibroids is a problem, then you mentioned she had a myomectomy already. Yeah.
Yes. Yes.
So other treatments would be the ultrasound treatment of the fibroids, where the fibroid actually shrinks in size due to the ultrasound waves of the fibroids. It actually destroys it. It's a new treatment that's been piloted at Central Manchester Foundation Trust, and uterine artery embolization. That is also something that's non-surgical, but can be considered for fibroids.
Okay. I think it's helpful to know about all these new treatments that are non-invasive, because as time goes on, these might become the primary treatment for fibroids. So what you've described is one is uterine artery embolization, where they block the blood supply to the fibroid, isn't it? And that causes it to shrink. Yeah. And the second thing you talked about was the ultrasound wave treatment, where they use ultrasound waves. So it's not the same as your normal ultrasound, but it's sort of ultrasonic waves to break down the fibroid. And for people here who have come across people with kidney stones, that is the same sort of background therapy that they're using to shrink the fibroids, isn't it?
Yes, and that's something that's not new to gynecology, but kind of new in the UK at the moment.
Okay. So ladies, these are things that are coming that may help with some of the problems we have. Now, because of chronic pelvic pain, it can cause lots and lots of problems with people. And you mentioned the use of antidepressants. Now, there's a concern about, someone's asked a question about dependency on antidepressants. Right. And they're worried about that. So for anybody on antidepressants or considering if they've been requested by their doctor to start taking, can you address the concern about dependency on medication like this?
Again, with medication, you want to use it as kind of a last resort, okay? First of all, if you can use non-pharmacological methods, I mentioned exercise, physiotherapy, acupuncture, hydrotherapy, all these various modalities. If that helps you with your pain relief, that's great. Sometimes it could be an adjunct to your pain relief. So you just use you can just use minimal doses of pain relief. Now, for some women, that is the last resort, using antidepressants. I suggest like a trial of it for 3 months at least. If it's not helping, then you can stop it. But if it is helping, and that is the only way of treatment, well, then you have to weigh the risk versus the benefits. Okay. If the benefits are for you to manage your pain and to be functional in your day-to-day life, well, then you have to weigh that up. So it's nothing that's forced upon you. You can choose to do it, but I do know people that can take it and they cut back on it after some time to see if their body can adapt without it. So that's also something you can do in conjunction with your doctor. I wouldn't suggest doing it on your own, but do it with support if you have used it for some time and you want to cut back on it.
Okay. And just a question here, it's an antidepressant. Mm-hmm. So how does it help with pain relief? Because it's not an analgesic.
No. So it has been found to modulate the way the nerve fibers process pain. So in this case, it's not used to treat depression, although you might be depressed from your illness. But if you didn't have the pain, you wouldn't be depressed. So it's not used to treat depression per se. But it has been found to be like a side effect of the drug, if you would say so.
Okay.
Because we know things like the oral contraceptive pill, it was first developed for control of contraception. But there were certain benefits of taking the oral contraceptive pill that helped with other conditions as well, such as period pains. And so some women, and sometimes acne, can be reduced with the oral contraceptive pill. So you may take it, not for the contraceptive benefits, but you take it for the other benefits. So similar thing with the antidepressants. It's not used for depression. It's not because, oh, the pain is in her head, so I'm just going to give her tablets for it. But research has found that it can modulate, it can change that perception of the pain that you feel.
Okay, that's really helpful. There are other questions here. We get questions from this angle almost every week with almost all our health hours, and it's about alternatives to medication.
Yeah.
So natural herbs. There's a question here about cannabis to help pain. What in your practice, are there any alternatives to pain relief to medication? Yeah. So the natural herbs and cannabis.
Okay, so not that gynecologists are trying. I wouldn't say that. I think a lot of the use of cannabis and CBD, it's called cannabis, the oil or the drops, that's not addictive, but they take, I think, the compound that is effective out of cannabis. All these things are being driven, obviously not by the medical world. Is mostly driven by alternative medicine. Now, I have nothing against alternative medicine, but I do believe more research needs to be done in these areas. We can't recommend cannabis because we know it's an addictive agent as well. The CBD oil is slightly different. It's not addictive, but it takes the active compound out of cannabis. And I know for some conditions that's been found to help with acute pain or chronic pain. Again, I can't recommend it because enough research hasn't been done on it. And as a body, the College of Obstetricians and Gynecologists haven't, released any definitive statement about use of that.
They haven't endorsed the use of cannabis
exactly.
for this. Okay.
Yeah.
Thank you. Someone's asked, we've talked about ultrasound for treatment of fibroids. They're saying that if you have multiple fibroids, is this still an appropriate treatment?
There's a particular sort, remember I mentioned fibroids can cause symptoms depending on where they're located, how big they get. So it may not be necessary to treat all the fibroids if you've got multiple fibroids. But if you've got very large fibroids, the ultrasound treatment may not be appropriate for that. The fibroids that is best for the ones that are located just under the lining of the womb, that's easily accessible for the ultrasound, because the ultrasound probe goes into the uterine cavity. So it can't treat fibroids that are too far away. Okay, it can't treat all the fibroids, but again, it depends on how many you have. So before the treatment, the gynecologist would have done a scan to assess how many fibroids there are. They may have done an MRI scan as well, and that can more accurately see how many fibroids or how large they are. So it can treat certain types of fibroids depending on the location.
Okay, so the gynecologist you see will be able to advise whether that's a reasonable treatment option for you.
That's right. Now,
this is a lady who's in her mid-40s and has always had a regular 28-day period, but now that she started to have periods twice a month. And the second one is only very slight for a couple of days at a time. Mm-hmm. But it's new. She feels that the second period is related to her when she ovulates, but it's just that it's never been associated with bleeding before. And whilst it's not strictly pelvic pain, it's all to do with the pelvis. So she's wondered whether you could address that and what she should do.
So pain, bleeding that's occurring twice a month at the age of 45, that needs to be investigated further. Okay, so that would mean a visit to your GP. We have certain guidelines in gynecology, and that age group with change in your menstruation, whether the bleeding is heavier or more frequent, needs further investigation at the gynecology unit. So that would include taking a biopsy of the lining of the womb. Some women, once that's considered all clear and it's no problem at all, the treatment for that could be what's called a Mirena, or actually burning off the lining of the womb so you don't have to bleed that frequently. So there are various treatment options for that. But to access that, you need to go through your GP first of all.
Okay, thank you. You know, the other thing that we know as Black women and Black doctors and Black patients mm-hmm. is that there's a lot of social and economic disadvantages tied up with health. And that's why I feel that our health hours are so important. So there's been a question about the fact that there's this myth that pain is all in your head. Mm. Does that put you at a disadvantage when you go and visit your GP? And also, we know the statistics surrounding outcomes for Black women in pregnancy. So do you think that whole myth about pain's usually just in your head, and that if you can, you're strong-willed, you can overcome it? Two, that if you're a Black woman, somehow you're much stronger than everybody else, and so you should be able to overcome. So what association do you have with that? Do you tend to find, because you probably will see everybody, so mm-hmm. do you tend to find, is there any relationship with length of the number of times you've been to your GP before someone is actually referred to a secondary care doctor like yourself? What's your experience?
My experience is that waiting times to see the gynecologist can be quite long, okay? Unless you're kind of fast tracked because the doctor thinks you've got cancer, but majority of the times that's not the case. But just to see a gynecologist, some patients can wait quite a long time. Obviously, we know COVID did not help this process, and that a lot of women had telephone consultations instead. But even though with the telephone consultations, they still need to be followed up with a face-to-face appointment. And this resulted, and there are delays for this. So there is, first of all, a long waiting time to, first of all, get that face-to-face. And sometimes there could be a waiting lag as well to get investigations, to get blood investigations. So by the time a diagnosis is reached, especially if you have to go through like a surgery, a laparoscopy for diagnosis, you know, it could be 6 months, it could be 4 to 6 months. And it's difficult. There's no doubt about it. It is difficult for women to, or any patient really, to go through that time lag. So that's why it's important to arm ourselves with education. What could I do in the meantime that can help my symptoms? What can I ask my GP to do for me? These are the things you need to talk about. In general, diagnosis such as endometriosis, diagnosis such as chronic pelvic pain. The definition in itself is more 6 months of pain.
6 months of pain.
6 months
oh
of
my
6 months of
Who
pain.
thought that definition up? It must be a man. Yeah, to expect somebody to have 6 months of pain before you're referred on to a specialist. Yeah, that just sounds crazy.
So that is what we consider to be chronic pelvic pain. Hopefully before then they would have started some investigations, but I don't want to say the doctor should wait for 6 months of pain before they refer you on. That shouldn't be the case. But, that is a definition, and that is what we're working with. So there must be better ways of controlling our pain, treating our pain, and more opportunities, because sometimes we have enough information, but we don't have enough of clinicians, or appointment times are quite long for specialist clinics such as pelvic pain clinics and clinical psychologists and physiotherapists. So all these things are constrained in our health service. And then to compound things, if you're Black, if you're a woman, it's difficult to sometimes approach your GP, who may not be in that demographic, who may be a man. Although some men are quite sensitive to these conditions. I'm not saying that they're not, but it would be nice to have more female gynecologists.
Absolutely, absolutely. We heard last week, or a couple of weeks ago it was, that, and we also heard this on International Women's Day, that you have women who you're not considered to have the criteria for referring on after you've had a miscarriage is that you need to have 3 miscarriages before you're referred on. And I think the more women talk about this, those of you who are female gynecologists in the Royal College and lobby for some of these guidelines to be rewritten, because, if you've gone through your 2nd miscarriage and then you go to your doctor and say, well, no, we're not going to refer you on until you've had your 3rd one. It just sounds ludicrous, doesn't it?
Yes, it's almost as if you're setting up someone for failure.
Absolutely.
But they've mentioned 3. I think the research has shown that after your 2nd miscarriage, after your 1st miscarriage, you still have a good chance of having a normal pregnancy. Even after your 2nd, you still have a good chance. I don't know the figures in my head, but there is still a really good chance of going through a normal pregnancy.
The problem is with all these figures, sorry to interrupt, is that with all these figures and facts, that this is a sort of an average, but they're not dealing with individual. So it's fine for them to say, based on research, this is what you think will happen. But in actual fact, you as a doctor are faced with an individual and having to explain that, because we have found that after you've had 2, you've still gone to have a normal pregnancy. Well, I would think that because they're saying that they say that means that they've had lots of women who've had to wait until they have 2, so they know. We shouldn't even know that statistic, as far as I'm concerned. Anyway, I'll go back to the questions. And so it falls into the category of the 6 months of pain. I cannot think of any condition that is related to the male body where you wait for 6 months before you be referred on. But that's by the by. So we've got another question here that says, when I get really bad pelvic pain if I sit for too long. And it's sometimes really difficult to walk, but it seems to be related to the pelvis. It happens, it doesn't happen all the time, but mainly when this person sits for a very long time. Should they see their GP? Even as a non-gynecologist, I would say yes. Don't feel, because you see, this is one of the things you want to also change, the narrative about that GPs are overwhelmed. and that if you have problems, you shouldn't go and see them. You must still continue to contact your GP. There may be alternatives to the old face-to-face, but you can still contact your GP for problems you have, and secondly, for your screening. They're still taking on screening. They're still doing consultations if you have problems. So yes, the news says that they're all overwhelmed and they're not seeing patients. Please, if you have a problem, you must see your GP. So I hope that's helpful.
Yes, I endorse that.
Yeah.
And also you were speaking about this lady who is having pain sitting for long periods of time, standing for long periods of time. That is one of the signs and symptoms of this pelvic congestion syndrome. So I know I mentioned it's a controversial diagnosis. A lot of gynecologists don't really believe in it. But there is a group that there's a subgroup of gynecologists that think it is a valid diagnosis, and the treatment for that is treating the pelvic. Well, first of all, diagnosing it properly with ultrasound scan that could detect the blood flow in the pelvis to see if there's any backward flow of the blood, where it should be going forward is actually pooling back into the pelvis. So. I know there are private clinics that deal with that, but not per se on our NHS. So again, that's an area for research that needs to be done to help these women who have tried everything and that have gone through all the various treatments and laparoscopies. And sometimes it can be seen on laparoscopy as well. The question is, how do we treat it? So again, a lot of research needs to be done in this pelvic congestion syndrome.
Yeah, that's interesting, and I would agree with that. There's a question here about period flows, and it says that when I have my period, on the second day, there's quite a substantial bit of flow. On the third day, it will be a bit more normal, and on the fourth day, it will stop. Is this something I need to worry about?
It sounds pretty much normal.
Yeah.
It sounds normal, kind of normal pattern of blood flow. And what's heavy for one woman may not be heavy for another. So it all depends on what you've experienced throughout your reproductive life. I know the textbooks say that a blood flow of more than 80 mils is considered heavy. Well, I think if that experience would suggest that that's quite small for some women, and that is just an average. So again, and do remember too that a lot of our research and a lot of figures haven't been done in women of color. Okay. And we have to keep that in mind as well.
Okay. Yeah, that's a good question. The other thing is that when people talk about heavy, although it's described in mils in the textbook, I don't know many women who measure it. So what practically, what would be considered as heavy, so that people have an idea of what they might be going around thinking that the fact that I have to change 3 times an hour is pretty normal because that's what I've always done. In actual fact, that might be considered quite heavy. So as a guide, what's heavy?
So heavy when it's when you're flooding, so it feels as if a tap is just open, okay, and the blood is coming up quickly and it's staining your underwear, and especially having you in embarrassing situations. So just that social aspect where your blood flow is a problem, in that it can cause flooding, clots, and cause embarrassment. It doesn't even have to be considered heavy. That is something you should just get checked out when it's causing a kind of social issues like that. So changing your pad, every hour because it's soaked, that's definitely heavy. When you're producing very large clots, I would say like big clots, like a small lime size. Those are big clots. So or anything bigger than that, that is considered heavy as well. So those are that's the kind of heavy bleeding that we're talking about.
Thank you. Yeah, so that's the issue really. If you're seeing big clots, if it's debilitating, the fact that when you on the first and second day of your period that you worry about going into social areas because you know that it's just going to be too heavy, then that's something that needs to be seen. So there's a question about somebody who's had a total abdominal hysterectomy last year, August last year, and they've had a CT abdomen now with and pelvis with contrast and MRI, and that's been said to be normal, but they still continue to have pelvic pain. They've had lots of admissions to A&E. Any additional advice, or if they're going to be referred to tertiary services, who'd be the best person to see them, especially now that they've had a hysterectomy?
Yeah, so that's one of the things I probably didn't mention in my little talk, that you can have pain after surgery, pain secondary to gynecological surgery. And this pain could be due to a nerve damage. It depends if this pain is stinging, throbbing sort of pain. It can be due to nerve damage. And usually the pain clinics are the best clinics to go to. And they are run by pain psychologists. They're also run by doctors specializing in pain, usually under the Department of Anesthesia. And they have different diagnosis and ways of diagnosing exactly what's the cause of the pain. Again, if it's a hysterectomy and the pain is in the vagina, it could be due to the cuff that is sewn at the time of the hysterectomy, and that could cause pain. Okay, granulation tissue, adhesions. These may not necessarily, these really don't show up on CT scans. So yeah, I think
it would be useful to refer to tertiary services for this individual case?
Yes, it would be. Yeah.
I hope that's answered your question. The other thing is we've got somebody who's sent a question about they're 39, almost 40, and their periods have recently stopped. And that's quite young for menopause, isn't it?
Yeah.
So what should they do?
Yeah, so that is considered premature. Menopause or premature ovarian failure, where you're not seeing your periods. And that again would need investigations. So your doctor would need to do some hormonal blood tests to see what your hormones are doing, see if there's a problem with the ovaries. They may need to do an ultrasound scan, see if there's any condition like polycystic ovaries, that syndrome that can cause reduction in your cycles. So yes, that warrants further investigation.
It does, because you're quite young, isn't it? And you need estrogen for quite a number of things. It's what keeps your skin looking good, and also the effect on your bones.
Yeah, effect on your bones, effect on your just sometimes your mental health and feeling well. So that estrogen is very important.
Okay. Thank you. And I think this is, again, we have this question. I always think it's nice to round up with some of the questions like this about, we've talked about alternative medications, but any sort of therapies, not medicines per se, of lifestyle choices that might modify pain. Now, we heard last week that there are not many lifestyle choices that can modify the effect of fibroids. If you've got fibroids, you need surgical intervention or things you've described to sort them out.
Yeah.
But just in terms of pain, what sorts of things for women who are here, who've tried lots of things, maybe additional things that they can use to try and help?
Right. So I would say specific exercises, Pilates, yoga, just gentle stretching of your muscles, of your pelvic floor especially. because as you get older, the pelvic floor is prone to prolapse, meaning it loses its support, and the womb and the cervix and the bladder can kind of hang down, sag down, causing dragging, that sort of dragging pain. So to prevent that, again, it's very, very useful to be doing your pelvic floor exercises. It also helps with your bladder conditions as well. And I think I mentioned acupuncture for pain. Now, again, that is coming more on stream. We're actually starting to use acupuncture for vomiting and nausea in pregnancy. And even cancer patients with a lot of symptoms of vomiting and nausea have been using acupuncture, but acupuncture is also useful for pain. Again, you need, you'll need a clinician, someone who's trained in that to do that sort of thing for you. But it's an alternative. It's a non-pharmacological alternative.
Okay. There's a lady who says that I've had pain at the top of my leg into my pelvic area.
Yeah.
And near the entrance to vagina, which is really affecting walking and standing. Mm-hmm. Any general advice about this? It's been going on for more than a month now.
Right. Okay. So this could be a trapped nerve. It could be, especially if it's a kind of stinging, burning pain. Again, you'd need to see your GP to advise about that. I mentioned earlier on about these medication you can take that helps to helps your body to process that pain a lot better. The nerve modulators, I would say. So that might be useful in that kind of chronic pain situation if it's not something acute.
Thank you, Patrice. Thank you so much. I think we don't have any more questions, but that's been a really, really useful session. I always like to ask our speakers for sort of take-home messages for people that join. And these sessions, I found them incredibly informative through the years. I think it's an immense privilege to be able to listen to all my colleagues every Saturday, because I myself take away health messages that I use for myself as well. So what would be your take-home message today for people having chronic pain? And what are maybe a couple of things that you think that they should really sort of consider?
First of all, don't think it's all in your head. Don't think you need to put up with it because society has told you that that is your role. Seek education, just as you're doing now. You're listening to medical professionals that you can trust, and seek that education, seek that information, and make informed choices. When faced with options, explore your options when it comes to pain management or management of your symptoms. Don't always just go with everything the doctor says. And keep a symptom diary, very important. Keep a diary of how you're feeling, what the symptoms you're having, the pain you're having. So that's my take-home message for today.
Thank you so much, Patrice. As I said, we find that those of us that host and our doctors, we hope that you find this incredibly useful. But it would be really helpful to us if you can give us some feedback, and also maybe mention the things that you'd like us to talk about, because this is a service for you that are dialing in for our community. We want you to feel empowered when you go and see your GP, so that you can ask the right questions and don't feel as if that your concerns and your worries are being fobbed off. It's a national health service that's in place for all of us, but we know because of the health inequities that we don't always access what we should. So hopefully, if you're here and you've listened today, you have something else that you can take in your armory of information that you go and see your GP, that you can enable them to listen to you. Because if you have information that gives a much clearer narrative to your GP where they can set out to help. So please fill in the feedback. Let CAHN know the topics that you'd like us to discuss. We usually have I find that we have more women, but if you're any men out there that you'd want us to discuss things that would be helpful to you as well, please pop it in the chat and contact CAHN. And I'm going to hand over to the CAHN team now, but whilst we're doing that, if you can also pop in the chat where you're from, where you're listening from today, so that we can have an idea of where all our listeners are accessing this from. But have a nice Saturday afternoon, and I'll hand over to CAHN team to give you a bit more information. But thank you for being with us.
Perfect. Thank you very much, Dr. Ngozi. It couldn't have been the best session to end the week, really. So special thanks to you, Dr. Ngozi, who is our medical lead. We're not going to stop appreciating you, you giving your time and everything. So very much appreciated. Thank you very much, Dr. Patrice Arter. Again, this is a very interesting topic and a month when we're talking about women. I myself have found it really, really useful. So thank you. Thank you for that. Thank you for your time, and hope to have you soon again. Thank you very much to everyone who attended the Zoom session. We know you have loads to do on a Saturday morning, but you gave this time today with us. So a massive thanks again to our viewers on Facebook and YouTube. Thank you so much. Cannot end this session without thanking our CATHIP partners, BHI in Leeds, RAFA International Development Agency in Birmingham, Croydon BME Forum, Enfield Caribbean Association, RCCG Sheffield. Thank you very much, because in your various areas you're pushing with these health hours. And again, I think last week we asked people to put a message in the chat, chat box about where they were joining us from. So again, if you can do that, that would be great. So if you would like to access the health hour, please note we're streaming now on YouTube and Facebook. The links are available. My colleagues have added the links in the chat box. I don't know if that can be added again, maybe for those who joined it late. And if you would like to have the slides presented by the doctor, please do email health@cahn.org.uk. Again, my colleague can add that in the chat box. We have for any feedback and evaluation, we have an online survey link. Again, my colleagues will kindly add that in the chat box. And if you can give us a minute of your time to fill out the poll, that appears on your screen at the end of each session. That'll be amazing. So in terms of the events we have every week, we also have another amazing health sessions, Healthy Heart. That is every Tuesday from 5:30 to 5:30 to 7:30. And you have an hour with a physical instructor and another hour with a nutritionist. I can only say it's amazing, guys. Just join in and pop in and see what goes on there. And in terms of the next health hour, the next session is next Saturday, the 26th of March. And we will be talking about polycystic ovarian syndrome with Dr. Karen. Again, something very close to our heart as women. If you know any other woman, please do share these messages, because we never know how someone's life can be changed. You heard the doctor mentioned, if you have any of these symptoms, contact your doctor. Sometimes we don't even know what the symptoms are. Sometimes we have them, we carry them, and we don't have a clue what consequences can derive from it. So please do attend the session and share with your friends and families. So at the moment, CAHN is running a crowdfunding campaign. So we'll really love you to to click on the link that my colleague will add again in the chat box. We recognize the need for counseling in the community, and with your help, more families will receive the necessary support. We're asking you to donate to our crowdfunding campaign to help us raise 10K in 4 weeks. Actually, we only have 1 week to go. So please do share the link with your friends and family, and we can help our community. So help us to help our communities, please. So thanks to our partners at National Health, at the National Emergency Trust. Any donation you give will be doubled. So again, that's amazing. So we have a portal. Again, please, Elizabeth, if that can be added in the chat box, just so that people know where to go. And I can only say, in terms of the support this can provide to our community, since COVID, since lockdown, our counseling service has had a massive increase in demand for the service, because people are really suffering, and we have all sorts, really. We have adults, we have children, we have young people, and we know people need the service, and all we want to do is to be there to support them. So if you would like access to support, you can also email us at help@cahn.org.uk, or you can contact our helpline 07710 022 382. Again, if my colleagues can add that in the chat box, that would be helpful. And via the helpline, you also have access to services such as advocacy service, domestic and sexual violence, counseling. We mentioned that earlier. In terms of advocacy, please, if you know of anybody who is going through any sort of challenges, please do refer them to us, because again, the community is going through stuff, but people don't just know where to go. There are many challenges, whether it's to do with employment, whether it's to do with children's services. We've had many cases, people having challenges with the children's services, social workers, hospital grievance, any sort, really. The fact that we have this service available, it's just a massive opening for our community, because many people didn't know of such services, mostly for the Black community. We also have a sporting activity. We're talking about health. We have sporting activities for women, young ladies, and I mean, young ladies, we're all young, from the age of 12 to the age of 45. Again, please, if you need more information, please email communityengagement@CAHN.org.uk. Again, we can have that in the chat box. We also have an upcoming event on 7th of April. We have a big writing workshop with MAC, Manchester Community Central. So, I mean, it's two events, really. The first one is on 7th of April, and the second, 7th of April from 9:30 a.m. till 1:30 p.m. And the second, it's on the 12th of April from 2:30 p.m. to 4:30 p.m. Again, we know that many of you run your own organizations, so our charities. It's going to be a really good opportunity to show how to write successful funding applications. So in a nutshell, that's me. Thank you very much, everybody, for attending the session, and over to you, Elizabeth. Have a lovely weekend, everybody.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.